Concerning the topography of the head, we can, looking at the introductory diagram, we can divide the regions in the superficial and deep. What we see are, in fact, the superficial ones belonging to the neural cranium or neural portion of the head. Good example is the frontal, parietal, occipital, temporal. Then those which belong to the facial part, like the orbital, nasal, oral, mental, parotidomasseteric, buccal. Some of them have two portions. One is superficial, one is deep. A good example is the orbit. Orbita has the palpebral region, palpebrae, which is the superficial, and the deep one, which is the orbit inside. But we start with a short review of the general structure, of general architecture of the superficial regions, and after that we'll follow the deep ones. If something will be missing, I will send you handouts immediately after the lecture. So the first diagram shows the superficial areas of the head. This is the forehead belonging to the neurocranium. That one is a facial part, a viscerocranium. In the subcutis, we usually see some superficial nerves, very small arteries, usually the veins which belong to the main vein draining the face. This is the facial vein, and also the main artery supplying the facial regions. This is the facial artery, but there are also the other ones. This is the superficial temporal, then branches of the ophthalmic. Ophthalmic is branch of the internal carotid supplying the orbit. Then we see the layer of the muscles, the superficial muscles, muscles of facial expression, ventral belly, anterior or frontal belly of the occipitofrontal, then orbicularis oculi, orbicularis oris, muscles belonging to the group of the muscles around the nose, etc. In the superficial regions, we can palpate also the main nerves or the branches of the sensory nerves. The face is innervated by the sensory innervation, by sensory branches of the supraorbital. Number one, this is the ophthalmic nerve, or also inferior by the infraorbital, belonging to the maxillary. Then mental, belonging to the inferior alveolar. That means the mandibular nerve, third branch. In fact, all these points where we can palpate the branches of the nerves are situated on one line, descending practically 3-4 millimeters lateral to the center of the pupilla. As an example of one of the regions, superficial ones, will be explained the parotidomasseteric. Here in the key position lies the parotid gland, large gland, salivary gland, with the duct, parotid duct. It's my book, so then I can color also the duct here. Okay, then we see the facial vein, facial artery with labial branches, inferior, superior, and so on. Then branches of the superficial temporal. By the way, here in these two areas, two arteries, we can palpate their pulsation. The one point is the point where the facial artery crosses the mandible, and the second one is on the squama of temporal bone, where we can palpate the pulsation of the superficial temporal artery. When we go deeper, so we see also, you see this is the parotid gland, and this is divided by the position, of course, of the facial nerve, which supplies also all the muscles of the facial expression. So there are branches passing through the parotid gland, forming the parotid plexus, etc., etc. So we just said some words to the general structure. So first of all, in a rich program, we try to do the best to complete everything. We are starting with a review. We could say just topography, topography of head, and topography of head comprising some topics. First of all, the number one would be the general description of and we would say this is the nerve supply, nerves and arteries of the soft tissues, of the soft covering, soft tissues of head. Practically means that we are speaking about a general sensory innervation and arterial supply of the arterial blood supplying the area. We need just one simple drawing, one simple diagram showing the superior view This is the superior, the outline of the superior view of the head. We could say superior view. For the orientation we use, we can frame it by green as usually, and then looking at the, of course, position of the auricles, dorsally superiorly. And note please that, first of all, we draw a line interconnecting the central parts of the auricles and dividing the head from the superior point of view into two asymmetrical halves. One is the dorsal, one is ventral. So starting on the left side could be what? Could be the nerves. What do you think? And on the right side, we would start with the arteries. So nerves and arteries, NN and AA. So concerning the nerves, first of all, they are the branches from the first branch. That means the frontal ophthalmic, definitely. Then the second branch, smaller branches, zygomatico-temporal, but auriculotemporal is thicker nerve. So increasing contrast of the nerves, we see all these like that, this and that. So starting with the trigeminus is 5/1. Frontal nerve, we could say frontal. We can use also sometimes the Latin words frontalis from the first branch. That one is the zygomatico-temporal, temporal sufficient, zygomatico-temporal from the second branch, from maxillary. And the third one is a little bigger, is the auriculotemporal from auriculotemporal nerve from the mandibular nerve. That means the third branch of trigeminal. Of course, there are more branches, definitely. So we just look at the area supplied. So first half or anterior half is supplied by the completely, including the face, by the trigeminus. Dorsally posteriorly is different situation. There are branches from the cervical plexus, segments C1, C2, C3, C4. So we are drawing just some branches, but all of them belong to the cervical plexus. So don't forget that this is the other branches of the cervical plexus. With the occipital is minor occipital nerve, and that one is major occipital nerve. Fine. So we can say that looking at the drawing, anterior part of the head, including the whole facial area, is supplied by the branches of the trigeminus, while the posterior half of the head, including the nuchal region, is supplied by the branches of the cervical plexus. That's the main orientation. Concerning the arteries, is similar situation. Ventrally anterior, there are arteries leaving the orbit as branches of the ophthalmic artery, and posteriorly in the same area are many branches of relatively thick superficial temporal artery. Dorsally, there is smaller posterior auricular, and finally larger occipital. So again, here we see the branches. We could say branches of ophthalmic artery. Note, all of us, we would add the information concerning the source of the artery. So ophthalmic artery is branch of the internal carotid artery. This one is the superficial temporal. We will speak about this artery as one of the most important arteries many times. So superficial temporal artery. This comes from the external carotid, again in brackets external carotid. So we see internal carotid, external carotid, and finally here's the posterior auricular, again posterior auricular branch of the external carotid, and finally that one is occipital, the same occipital, again artery, external carotid. So concerning distribution of the arteries, the principal blood supply gives the supply comes from the external carotid, smaller part from the internal carotid, because internal carotid primarily supplies the brain and of course the central nervous system, together with the vertebral artery that supplies also the vertebral canal and the brain. So these are the arteries. Concerning the veins, simply the veins are drained into two bigger veins. They are the ophthalmic veins anteriorly, ophthalmic veins. They drain into the some different sources like the sinuses in the cranial cavity, or separately into the retromandibular vein. Retromandibular vein is one of the main veins collecting blood from the dorsal side of the head. We will see some diagrams. Important is the lymphatic drainage. Always important is lymphatic drainage. So it's a lymph is drained into the nodi lymphoidei, or simply lymph nodes. There are some groups laterally parotidei, we call them, official term is nodi lymphoidei, parotidei, or parotid lymph nodes. Then second group are situated behind the auricle, so retroauricular, but also suboccipital and servus, and we could say occipital lymph node. So there are three areas where is drained the lymph. No, this is the superficial view. So we are looking at the surface of the soft tissues on the surface. We need one diagram which shows not only the soft tissues you have seen it on Monday in the lecture, but there are some notes, minimum a few minutes, where we can explain also the cranial cavity, where we describe the spaces between the meninges. So we could add the diagram where we will see the spaces between the meninges. Meninges, we know that from the meninges from the high school. We know that there are three meninges, which are dura mater, the thick one, the external one, number one. Number two is the arachnoid, from the Greek word spider, arachnoid mater. And number three is pia mater, is firmly, I would add just one word, is firmly attached to the cortex, of the brain. No, this topic will be discussed again in the summer term together with the central nervous system. But now we need just few notes quickly. And for these three layers, we use different colors. One will be green, one will be red, and one will be violet. So please follow me and draw one simple diagram showing also the cranial cavity, because we are speaking about the layers on the surface, the scalp, but we cannot ignore the situation where we see the scalp and also the deep layers. So looking at the scalp, there are the soft tissues with the hair, definitely. Then there is a subcutaneous connective tissue, then aponeurosis, the lamina, thick lamina, we will speak about aponeurosis. And then we have here the periosteum. So that's all. So all these layers represent soft tissues on the skull, and then follows the layer of the external and internal lamina of the bone. So that's why using yellow to color the bone. And then follows now we are in the cranial cavity, where is the periosteum plus the peripheral layer of the dura. So this is dura mater, using green, as we said. And also the dura forms the duplicatures in which are situated the venous channels or sinuses. So just one simple, very simple diagram, because this will be repeated again. Look, here we have dura. This is also, again, dura, and this is also dura, duplicature of dura. The folding, we call it also folding. And inside dura, we draw, first of all, some specific structures belonging to the arachnoid. So just sketching arachnoid, this is like that, and also on this side, arachnoid, and then increasing contrast as we see, like that, then coloring the space by blue, showing the vein, venous blood. This is here, and here is also vein. So these venous channels are called sinuses. So here is the superior, because I will show you also, one of the biggest one is the superior sagittal sinus, superior sagittal sinus, and here is the inferior sagittal sinus, superior inferior sagittal sinus. Again, the sinuses are vascular venous channels without valves. And then the red color indicates the arachnoid, and arachnoid has many trabecular systems, the trabeculae, like here, and the trabeculae are important for the stability of the space, which would be called subarachnoid. Then follows pia, the last one, drawing just very small part of pia. And as you see, pia is firmly adherent, attached to the cortex. So just the dotted line indicates the position of the cortex. That's it. So we could say cortex, just cortex of the brain. So reddish is arachnoid, and light violet is pia. Maybe here we can add pia. So, and then speaking about the spaces, nothing, no details, we don't need anything, just one arrow is placed into special elevation of the arachnoid. We call it arachnoid granulation or granulations, and the arachnoid granulations represent the places where is resorbed. So I would add resorption of the cerebrospinal fluid. Full name, cerebrospinal fluid. Everyone knows that cerebrospinal fluid is produced by the cavities, by the plexuses inside the ventricular system of the brain. But the fluid is found here, flows through the spaces, and is resorbed into the arachnoid granulation. So discussing the spaces. So space, I would say space, and for space we could use some symbols, dots, for instance, dots. Good. First of all, this is like that, correct. So first dot lies in the potential space between the dura and bone. So we call it, because of the position, this is the epidural space. Number one, epidural space contains the meningeal arteries. There are three arteries: anterior, middle, and posterior. Middle is the most frequent or most stable in the position. Meningeal artery passes through the spinous foramen, foramen, just to know that meningeal artery is a branch of the maxillary artery. So from maxillary. So if we repeat again and again, the sources is always good for the students. The second space using two dots is called subdural. Two dots, subdural space. Subdural, and subdural space contains the bridging veins. Bridging. I will draw also in the diagram the bridging veins. And finally, the last one is the subarachnoid. Simply using red, one cross indicates subarachnoid, which is the largest one, subarachnoid space. And subarachnoid space contains the cerebral arteries plus veins plus cerebrospinal fluid. We know the abbreviation. Here is the cerebrospinal fluid. Again, repeating. So concerning the veins, concerning the arteries. So meningeal artery is easy to understand because it lies here, and I will show you immediately the situation in the atlas. Here we have the Grant's atlas, and in this atlas we see the position of the meningeal artery. This is the middle meningeal artery dividing into the frontal and parietal branches. Then we see on the other diagram the position of the veins which are situated within or in the diploe. They are called diploic veins. Veins which have many connections with the extracranial and intracranial veins. This is the second one. And the next diagram shows also the layers. This is practically the same. Here is the sinus, the superosagittal sinus, the inferior, etc., etc. We see also the cortex, the layers of the scalp. Here are the veins found in the vessels in the external layer. And then what is important for us to understand that in some cases of the fractures of the skull, then follows the rupture of the vessels and hematoma. So we call them hematoma. And according to the location of the vessels, which are ruptures producing or opening the area for flow of blood, so we call them. So this one is called extradural or epidural hematoma. That one is subdural from the bridging veins, and that one is subarachnoid. So we see three different hematomas. Looking at them at the diagram again, we have to complete the last point concerning the position of the veins. Here we see they are the extracranial veins, which have the connections with the deep ones, like in our diagram. This could be a good example. We call this perforating veins emissary veins. So you could just name them. Here we see the cranial, the best way, general name, extracranial veins. Then these are called emissary vein or veins. Emissarium is the name for the opening canal perforation. These ones are diploic vein or diploic veins. And finally, the diploic veins have the interconnections with the sinus, like the perforating bedded bridging veins. So the bridging veins, as we said, are those veins, right? These are bridging veins. No? So there are three hematomas, and then hematome. A hematome we can write, or we can see again. You look, this is the hematoma. Located in different position, because hematoma, definitely, and all these vessels can be ruptured, bleeding. I would say bleeding, yes, bleeding causing hematoma. So hematoma is the accumulation of the blood in specific spaces. Details are not necessary. This is just general information concerning the hematomes, because we have to understand that they are also not in the external but also internal systems and layers. That's it completely. On Monday you had the you described all the structures also on the surface, including some deep structures found in the ear cavity, that means the middle ear cavity and internal ear. So we have to say some words also to the external ear, where we see the auricle. Before that, one or two diagrams showing the last diagrams, again the granulations, you see the bridging veins, and then the spaces. As we said, here we see also duplicatures of the dura. So dura has some duplications. That one is the falx cerebri, and we haven't mentioned. No, why not? We haven't mentioned that this is the falx cerebri. Why not falx cerebri? And you could add that falx cerebri is duplicature or folding, duplicature of dura. Dividing or separating the hemispheres of the brain. This is sufficient, absolutely sufficient. Looking at the auricle, we will not draw any details. There is absolutely no reason. Just looking at the typical view. What is important for us are also the areas supplied by three different nerves, because we were speaking about the nerve supply and blood supply. So this was corresponding with our first diagram. Here we see also the opening into the external acoustic meatus, and also at the end of meatus lies the eardrum, the tympanum. Here is the section showing the whole ear as the organ. We know that ear is divided into the external ear, then middle ear, and internal ear inside. And this is the auricle. Then follows the meatus, the external acoustic meatus, which is cartilaginous, 2/3 external, 1/3 is bony. And then at the end of the meatus lies this obliquely positioned the tympanum, the eardrum, as we see. Then follow three ossicles, like the levers transmitting the mechanical movements of the eardrum into the internal ear. And don't forget that here in the middle ear cavity there is also opening into the nasopharynx. There is the orifice of the tuba auditiva, the Eustachian tube. Maybe that another diagram from your book shows the position of the ossicles, where we see malleus, incus, and stapes. Again, the general view, the external surface of the tympanum, then attachment of this manubrium of the malleus to the eardrum, and then follow again the body, etc. So we call it malleus, incus, stapes. Here is the cleft, the opening for the Eustachian tube, tuba auditiva. Another view, we see again two ossicles, malleus, incus. Note please that we will speak about the corda tympani. So just look at that. Corda tympani represents the branch, very important branch of the facial nerve, passing through the cleft between the malleus and incus, and supplies finally, together with the lingual nerve, the submandibular glands, and also the anterior 2/3 of the tongue. We will speak about that later. And then there are also muscles. We will speak about we will try to look at the short review of the muscles of the head. Here is the muscle which is called tensor. This is in fact tensor tympani muscle, because this is the tensor which is attached here, and tensor keeps the position of the tympanum in tension. So it must be under tension. This is one thing. And here is the stapedius. Stapedius is attached to stapes. Maybe it would be better drawing that one. Again, looking even better, because we see also the facial nerve. You see facial nerve descending in the facial canal, leaving the canal in the stylomastoid foramen between the stylal process and mastoid. Here we are in the middle ear cavity again, and then you see the stapedius attached to stapes, because stapes is, as we have seen one of the first diagrams, is pushed into the internal ear, so it must be pulled again back. and this one is the tensor tympani attached to the tympanum. Well, so I mean that this is sufficient for us. So we would say just the, why not to say external ear, and external ear nerves plus vessels, because not details, as we said, details will be studied as a whole organ. We know the ear is the organ of hearing, an organ of balance, equilibrium. This is what also we know. When we look at the auricle quickly, just sketching, if we see the auricle, yes, this is the helix, and so lobule, sufficient, and that one, looking at Darwin tubercle, this is like that, sufficient, and then here are the lines indicating the depression here, this and that, and then one process called tragus. So I mean that this is more than sufficient. Concerning the terminology, why not to use some names? Auricle, this one is called helix, opposite is anhelix, then depression, here is the concha, sufficient, then the anterior tubercle is called tragus. We can palpate this tragus. Why not to look at the lobulus? This is sufficient, this external description. But we need what? We need a red color like that, drawing 3 areas which are supplied by different nerves. This corresponds with our idea to describe the external ear, looking at the nerves. So in yellow, we see the greater auricular from the cervical plexus is greater auricular. Auricularis magnus, auricular nerve, greater auricular. Then without color could be that one, which is occipitalis minor nerve, nervus occipitalis minor, and the last one using light blue, very light blue, like this one, and the whole area definitely is supplied by the nerve ascending here as the auriculotemporal. So auriculotemporal nerve, and this comes from the cranial nerve 5/3 mandibular. So we see distribution of the nerves supplying the auricle, the external ear lobule. Concerning the construction or material, don't forget that the auricle consists of the elastic cartilage. No. Concerning the arteries, just quickly, because we have to also define the arteries. Logically, artery which runs together with the auriculotemporal, so we call it temporal superficial. We remember the temporal superficial artery is the main artery supplying the lateral part of the whole head, you see, including the scalp. So superficial temporal. Then what else? Posterior auricular, also auricular. We have seen auricular artery. This is, as we remember, that one is anteriorly, posteriorly, finished, done. So this is the arterial supply. Veins are the same. What to say? Veins are same practically, and they open into the general, in the internal jugular vein, because they open in different smaller veins, but generally, finally, in that one, sufficient. Good. So this is this one. Nerves, we said, nerves are already defined. So nerves, but nerves are divided into the motor branches, motor nerve, motor innervation, coming from nerve number 7. This is the facial nerve, as all the muscles in the face, and sensory general sensation. See diagram see figure, we said. Fine. Concerning the acoustic meatus, we have seen diagram. External acoustic meatus, maybe not bad to say external acoustic meatus, and the external acoustic meatus is the tube which runs lateromedially internally. It's bent, as you see, but in two dimensions, antero-posterior lateromedially. So then the acoustic meatus, I don't have any extra drawing showing the external acoustic meatus, but this one may be sufficient. The acoustic meatus is the, no, I don't have anything else, but doesn't matter. Just we could say that just sketching the position of external acoustic meatus, this will be like that. What we see using green is the position of the tympanic membrane. This is that membrane. So eardrum or tympanic membrane. Tympanum also. Tympanum is the international name. You see the channel, which is narrower here. We call it isthmus inside, and the dimension of the isthmus is approximately 7.5 to 7.8 millimeters. The length ventrally is 35 millimeters, and ventrally dorsally 25. So the length is on the ventral side is around 35 millimeters, and dorsally posteriorly approximately 25 millimeters. And we said that the laterally 2/3 consists of cartilage, and 1/3 is bone. Okay, bony and cartilaginous portion, absolutely sufficient. That's good. And nerves supplying the canal acoustic meatus is again the auriculotemporal, the same as the auricle plus auriculotemporal, but also the branches of the other nerves, cranial nerves branch of number 9, number 10, and number 7. We call them rami auriculares branches. No, this is good. No, and at the end, because this is this is one part, right? This external portion, right? This external portion, and at the end lies the eardrum, the tympanic membrane, yes, and tympanic membrane, as we can look from external side, lies within the small depression. In the depression lies the circle, like the annulus, we call it fibrocartilaginous ring, fibrocartilaginous ring. Two folds indicate the area. We could cut by yellow. This is called pars flaccida. Pars is part, flaccid or flaccida. We can use also original name, pars flaccid or flaccid part, which is relaxed, and the rest is the pars tensa, under tension, that one, the white one. And here what we see is the attachment of the manubrium, so internally we see the attachment. We have seen diagram attachment of the manubrium, the handle manubrium of malleus to the eardrum. That central part, the tip, is called umbo, small depression. So this pars tensa is much bigger than pars flaccida, and we can also divide the eardrum following the line of the umbo into four quadrants. Important for description of the for the medical purposes, for ENT otolaryngology. Also in the second, so this is number 1, number 2, number 3, number 4 quadrants. And here we see also the reflex, the light reflex, when we look using light into surface of the eardrum, light reflex. Also here passes the on the internal side the arch of the chorda tympani. So I mean that this is more than sufficient. Concerning the position of membrane, of the tympanic membrane, is not strictly vertical, it's oblique. So it's oblique position. And concerning the related to horizontal line or horizontal plane, which is around 40 degrees to 50 degrees. We call it inclination, and horizontal plane, and sagittal plane 50 degrees, we call it declination. Good, sufficient, done. Then we have to say some words to the review of the muscles. So muscles of the head, quickly, definitely of the head, and as the short review, because the main task is to start with the regions, describe some of them. When we look at the muscles, we fully understand that muscles have different origin and logically also different nerve supply. There are some groups. First group is the specific group, muscles derived of the muscles of the, using capital letters, branchial arches. We remember that branchial arches give off or contain or consist of material, ectodermal, endodermal, which give rise to many organs, many structures. They develop, or they surround developing pharynx, and they are 6 arches together. And then, okay, we can start with 1 or 2 diagrams showing the arches. This is the lateral view when we see when we see also developing arteries, but they are arches. Look, and then first of all we see the trachea and developing esophagus, etc. The first part of the digestive system. They have also some depressions, the pouches between them, but this is not all. Better is to look at this diagram where we see the arches. First one is called mandibular, second is hyoid, the third one, they don't have a name, third, fourth, fifth disappeared, and then 6 is the last one. So first one is called mandibular, the second is hyoid, connected with first with the trigeminal, second with the nerve number 7. This is with number 9, etc. So these arches are situated one by one, and they finally form not only the structures, different structures, but also the muscles. Revising, the first one gives rise to the gives rise to the malleus incus. The second one, hyoid the stapes, styloid process, stylohyoid ligament. Then we see number 3, the hyoid bone with the greater wing, lesser wing, etc. And then the following, they give rise to the cartilages of the larynx and the trachea. So we start with the first group, muscles of the bronchial arches. In the one of the next lectures, we'll speak also speak about the organs, bronchial organs. You see, this is the material which has the origin in the bronchial arches. So number 1, first arch is called mandibular arch, which gives rise, that is connected with cranial nerve number 5, always with 5/3, because the mandibular nerve innervates, mandibular will be in the red, and innervates the muscles of mastication or masticatory, we could say masticatory muscles. They are, all of them are innervated by nerve number 5, but also the digastric. We will speak about the digastric, later digastric, the anterior belly, belonging to the suprahyoid muscles. Then also mylohyoid. We know that mylohyoid was described together with the floor of the oral cavity. And then 2 tensors, musculus tensor of palatine velum of the soft palate. The original term is veli palatini, also supplied by mandible, and musculus tensor. We have seen diagram tensor tympani. We said that tensor tympani is responsible for the pars tensa, for the position of the tympanum. Correct. This is first arch. The second is hyoid arch, always connected with cranial nerve number 7. Yes, and number 7 means that the facial nerve innervates the next page, innervates the muscles of facial expression. So innervates the muscles of the facial expression of facial muscles. Okay, we can use both terms, expression or facial muscles. That's it. Then also stapedius. Stapedius, we said, and we have discussed the diagram stylohyoid. Stylohyoid is the muscle descending from the styloid process, attached to the hyoid bone, important for the movements of the hyoid bone. You see, together with the muscles contracting the pharynx, that means during swallowing. Then digastric, again, logically the posterior belly, and all muscles of the auricle. We will not speak about muscles of the auricle because they are rudimental muscles, so we don't need them as human beings. Correct. Arch number 3, it doesn't have a specific name, connected with cranial nerve number 9, always number 9. This arch has practically, concerning muscles, only one muscle, and this is the stylopharyngeus. As the name says, it elevates the pharynx attached to the styloid process. The 4th arch, also without a specific name, connected with the cranial nerve number 10, vagus, and this nerve innervates the muscles of soft palate, and also the pharynx, because there is the complex of the plexus together with the nerve number 9, and also number 5 disappeared, nothing. Number 6 is the last one, connected, last arch connected with cranial nerve number 9. No, sorry, 11, 9, I already mentioned. 11 accessory. So we see the last one, last arch, and this innervates the muscles of larynx, but take care together with the cranial nerve number 10, because it runs together. So I mean that this is absolutely sufficient to understand that there is a short view of the muscles which that have origin in the arches. Concerning the second category, it was A, then follows B, and they are the other muscles, other muscles. That means the muscles of different origin. First of all, number 1 are the muscles of the we call it tympanic, of the tympanic cavity or middle ear cavity. Again, tympanic cavity. We have seen them, just names. This is the stapedius attached to the stapes, and the second one is tensor tympani. Again, we remember that tensor tympani is attached to the malleus, the tympanum, eardrum. Good. This is sufficient. Then this is the first group, muscles of the middle cavity. Then follows the category number 2, muscles of tongue, special group. We call them extrinsic, intrinsic. All of them intrinsic. They are innervated by cranial number 12, and they belong to the that special part of the oral cavity. So we will not speak more about them. Then there are muscles of pharynx. Again, just to know that they are supplied by cranial nerve number 10 plus 9. We said the number 4, they are muscles of the orbita. We could say orbital muscles, and these muscles have 2 categories because they are the muscles called extrabulbar, extraocular, or extrabulbar. Extrabulbar muscles are 6 in number. Extrabulbar muscles are attached, or they originate from the bone, run ventrally, and are attached at different parts of the bulb. Here we see the bulbus oculado, the bulb, bulbus. Then we see the straight muscles, musculi recti, superior, inferior, lateral. Here is the medial, and 2 oblique, superior and inferior. Look, that superior originates again as the other ones from the tendinous ring in the tip of the pyramid, because this is like pyramid, the orbit. This is the medial wall, lateral wall. It runs dorsoventrally, then passes through the trochlea. This is the fibrous attachment to the anterior part of the medial wall of the orbit, and then runs dorsally, being attached to the posterior half of the bulb, behind that circle, the equator. No, and then we see also the inferior oblique. So the oblique muscles are responsible for the torsions. In general, there are 3 types of the movements. That means elevation, and depression. We don't see any elevation that much because they cooperate. No, elevation is movement. Cranial up and down, elevation, depression. Then torsion around the longitudinal axis, medial and lateral rotation torsion, and also the movement medially and laterally are like the adduction, abduction. But note please that this is very important, it should be underlined, that the muscles, they don't act as the separate ones, or all of them they cooperate in the complex of the movements. The muscles are innervated by 3 nerves. So just summary, there are 4 recti, and 2 oblique muscles. So 4 recti and 2 oblique. They are the lateral, medial, superior, inferior, and oblique is superior. Inferior, concerning the nerve supply, we could say that lateral is supplied by cranial nerve number 6, other ones by cranial number 3. Superior is number 4, inferior is number 3. No, easy. So we know also the nerve supply of all them. But they are the extrabulbar. But in the orbit, we see also the other muscles, like the ciliary muscle. Ciliary muscle, again, we would, here we see the, maybe, the best drawing. We see the horizontal section of the bulb with the cornea and sclera, cornea, anterior chamber, the lens. But note please that here, note that there is the ciliary muscle responsible for the movement of the lens, which is important for the accommodation. So this is smooth muscle. Smooth muscle is innervated by the autonomic nerves, but parasympathetic innervation. I know that we speak about the skeletal muscles, the striated muscles, but if we mention the muscles in the orbit, we have to mention also ciliary. So ciliary muscle innervated by the parasympathetic nerves. So, and we could add accommodation, just information for all of us. And also another, we call them tarsal muscles. Tarsal muscles found in the tarsus, better in the palpebra, and they're found in the palpebrae. When we look at any, maybe this diagram, by the way, here we see the bulbus, bulb lens. This is the optic nerve, superior rectus, inferior oblique. That one is levator of palpebra, because this is palpebral muscle. And also here, the small muscles are called tarsal because they are attached to the tarsus, the plate, tarsal plate, and they just keep in the they are attached because they are in fact elevators of the, or tensors of the palpebra. So that's why also smooth muscles innervated by the sympathetic, also we could say autonomic nerves or sympathetic innervation, sympathetic, and I would say are attached to tarsal plates of the palpebrae, the lids. Fine. So I mean that we said all of what was important. These two are very specific, no? And finally, was number 4, number 5, muscles of the soft palate. There is no place, palate, but on the next page, we will see muscles of the soft palate. They are regular muscles responsible for the movements of the palate. We have to add also here the levator palpebrae, because we have seen it, palpebrae superioris levator. So this is the last one, but this is not muscle of the bulb. This is the muscle of the upper lip. No, concerning the muscles of soft palate, easy to see. These muscles. No, one drawing. What do you think about the coronal section? Quick view, coronal section. Looking at time, good. Concerning the muscles of the soft palate, 1/2 as usually. Starting with a plate of the dense connective tissue, fibrous lamina, we call it aponeurosis of palate, aponeurosis palatina of palate, or palatal aponeurosis, to which are attached all the other muscles like uvular muscle, then levator of the palate, then tensor runs around the hamulus of the pterygoid process of the sphenoid bone, and there are two muscles descending here, which are in fact the palatoglossus and palatopharyngeus. Look at that. So then the names, first of all, levator, and we use the official term levator of soft palate or levator veli palatini. Velum palatinum is the soft palate, veli palatini. Then here's the hamulus around which runs the tensor. So the second one is a tensor, veli palatini. Then that one is uvula, why not? Uvula muscle. Then here must be the tongue. This is, we are looking from behind tongue. And then this one is the palatoglossal glossus, and that one is palatopharyngeus, palatoglossus, palatos, and palatopharyngeus. No. In light violet is the palatine tonsil. Just put here tonsilla palatina. Fine. It lies in the depression in the fossa. No. Concerning the actions, no. Uvula elevates the soft palate. Levator veli palatine, definitely. Tensor is responsible for the increasing tension. So then they are arrows, quite clear. But concerning the palatoglossus, so palatoglossus depresses the soft palate, but also raises the tongue. The same is palatopharyngeus, because decreasing and elevating the pharyngeal wall during swallowing. So this was all. Then this was group number 5. Number 6 are the muscles of mastication. So masticatory muscles. For masticatory muscles, we don't need any extra drawing because everything is explained in the atlases, and we don't have that much time because the more important for us will be also the short description of the regions as the topographic regions. But for any case, concerning the innervation of the muscles of soft palate is easy. They are innervated by the we have to add yellow, so nerves supplying the palate are number 9 plus 10 as the plexus, but with exception of the tensor veli palatini, so tensor not. Tensor is innervated by mandibular again. So all the tensors, in fact, are innervated by the mandibular nerve. This is what we said. They are derived from the first or mandibular branchial arch. Concerning the muscles of mastication, all of them are innervated by the nerve number 5/3. So they have fascia, are covered by fasciae. They have fasciae, and they have origin. Origin also on the bone, bony origin, and attachment or insertion. Insertion is also bone. That means mandible. So this is difference between the muscles of mastication and muscles of facial expression, because muscles of facial expressions are attached to the subcutis or to the other muscles. We can start with some diagrams, not so many. This would be here the best ones. Muscles of mastication, why not? Starting with the first one, strong elevator of the mandible, the masseter, which has the obliquely passing superficial head, and the deep one is more vertical. So when we look at the movement of the mandible during contraction, it's elevator and protractor. Elevator running superiorly and protractor moving the mandible ventrally. That's why there are movements with specific names. The second one is the temporalis. It is a flat muscle situated in the large area called temporal fossa, has the attachment to the coronoid process of the mandible, and it has also the horizontally passing fibers. So it's strong elevator and also retractor, so moving the mandible dorsally posteriorly. You see again the position. This is the position of the origin of the temporalis. Here we see origin of the masseter on the inferior part of the zygomatic attachment of the mandible, nothing else. Then we see the medial pterygoid. Medial pterygoid is muscle having also superficial deep part, but doesn't matter, is attached on the contralateral side of the mandible. That means the angle of the mandible is elevator and protractor, and its brother, the lateral pterygoid, as you see it here, has also superior inferior head, and superior head is attached to the fibrous capsule or to capsule of the temporomandibular joint, and the inferior is attached to the pterygoid fossa of the mandible. So both of them are protractors. If these two muscles cooperate, they produce also the lateral pulsion, lateral position. Now follow the muscles of the face, and then not yet. Here, maybe here is the last view. We are looking at the cross-section of the temporomandibular joint. Here is the Zenker's fusion. The fusion, we will speak about that together with the veins of the face. This is the complex of the venous channels. They are connected with the pterygoid process. And then look again at here is the capsule of the joint, complicated shape, attachment of the superior head, which is attached to the capsule and through capsule also to the disc directly, because disc moves together with the moving head of the mandible during elevation and depression. So opening and closing the mouth. During opening mouth, the head rotates, but also glides or slides on the surface of the tubercle up to the tip of the tubercle, and the inferior head is attached to the mandible. So they are protractors. This muscle is typical protractor of the mandible. So looking again at the view, A is the masseter muscle. Just we could say it has a superficial and deep part like that, because there is no that much time, and you can look again in the atlases, superficial and deep part, and this produces this is elevator and protractor of the mandible. B is the temporal muscle, temporalis. We will speak about the temporalis again together with the temporal area, temporal fossa. Temporalis is elevator again, strong elevator, but also retractor, moving the mandible dorsally posteriorly. Then next one is lateral pterygoid. Lateral pterygoid muscle is the muscle that is responsible for the protraction. It has also two parts. One is superior head, or heads also, we call it so heads. Students studying dentistry, they have to know in detail all the muscles, their origin, insertion, etc. So two heads, superior, inferior. Just note that superior is attached to capsule of temporomandibular joint and discus, and inferior is attached to mandible, to neck of mandible. This is specific position because they run dorsoventrally. They are protractors, so protraction, responsible for protraction, and if they cooperate both together, medial lateral, also we could say lateral pulsion, lateral position, or lateral pulsion. lateral position by chewing. No, and the last one is D, is the medial pterygoid, its brother, pterygoid. Medial pterygoid is the muscle, which is also two parts. One is superficial, one is deep. Superficial and deep, that's it. And finally, the medial is again, this is elevator, so elevation must be better handwriting elevation, and then also slight protractor, but protraction should be mentioned, protraction, and again lateral pulsion. That's it. So there are muscles called muscles of the mastication. And the last group is number 7, facial muscles, or we could say muscles of facial expression or muscles of the face, as you wish. All of them are innervated by cranial number 7. It was clarified. We have some categories. A, instead numbers, we would use letters. No. First of all, before we start with the categories, they don't have fascia, so they in fact there is just no fascia, because if they have some fibers, it's not fascia. Origin is on the bone. Insertion in the subcutaneous tissue or other muscles, or connective tissue like modulus, etc. tissue. This is difference. So we know the nerve supply, we know the characteristics. Starting with A, muscles of scalp. Yes, muscles of scalp means muscles of the superficial part, cover, or muscles attached to the coverings of the skull. Maybe that this drawing would be, this figure would be the best. We see that the muscle is called epicranius. It has the ventral belly, anterior belly, and then also posterior belly. That one is shorter usually. And also here we see the temporoparietal running from the rudimental muscles of the auricle. This is absolutely good. They are attached to the galea aponeurotica, as you see, moving also the whole skull. This is first group, first category. Maybe that we don't need an extra diagram, but just sketch is not wrong. Auricle, frontal belly, occipital belly, and then temporoparietal portion, just like that, using red ventral belly, dorsal posterior belly, and that oblique part, and then using green interconnecting all these bellies, and this central part is called galea aponeurotic, galea aponeurotica. So why not use galea aponeurotica, aponeurotic galea, which is central portion. Here is the ventral belly or anterior belly, ventral belly. That one is the posterior or occipital belly, yes. And the last one, as we have seen, is temporoparietal. Temporoparietal is, so here is the place, temporoparietal part. Okay, so this is quite clear, nothing else. General name is the muscles of the scalp, and the muscle is the epicranius muscle, musculus epicranius. Good. The following, this is A, so then first A, then B. B, category B, are the muscles, muscles of nose, of the nose, of course, of the external nose. These muscles are situated on the lateral side of the nose. Maybe that one sketch could help. Just looking at the nose. Here is the nostril opening in the nose are nares or also nostrils, nares, nostrils, like that, and upper lip. Just we see also the position of the orbit. It has the transversal and alar portion, transversal and alar part, and small part is called depressor septi. So part is the transverse part, this one, then alar part, alar or ala, and here a small depressor septi, could be variable depressor septi muscle, just depressing the septum, depressor septi. That's it. No, here's also procerus. It lies above that. It's not bad to know that there is also procerus. Procerus is responsible for the horizontally passing wrinkles. I'm sure that this is good. Then see muscles around orbit, muscles around orbit. Also quickly, muscles around orbit. No, we could use the same drawing or similar to that. Nose like that, correct. And then what else? The orbit. Orbit contains the orbicularis oculi with the in darker red the peripheral orbital portion and light palpebral portion. We see also the angle and ligaments there at the moment not necessary. Orbicularis oculi, which consists of parts of the following parts. This one would be one dot is the peripheral or orbital part, that one is the palpebral, and there is also the last one, which is not seen because it lies inside. I'm drawing just green arrow, and this green arrow indicates the deep part which compresses the lacrimal sac. It's called lacrimal part, and it acts as the compressor of the lacrimal duct. Correct. Pushing the tears into the nasal cavity. That's it. So, and then there is also a muscle situated as a supercilium. This is corrugator of supercilium. So this is one orbicularis oculi, superciliar corrugator, and also depressor supercilii, that one. So we need also orbicularis would be first one. Yes, this one is the corrugator CS. CS is the next one. Corrugator supercili or of supercilium. It makes the obliquely passing wrinkles or produces the wrinkles. And the third one is the last one, which is the depressor supercilii at the S. Corrugator supercilium is the CS, and depressor of supercilium is the DS. No one, depressor This logical depresses the supercilium. Finished, and then in this place, it is sufficient for category D, and there are muscles around mouth, muscles around the oral cavity, around mouth is even better. And these muscles consist of, or they represent two groups. They are circular. There is a circular sphincter. This is a circular constrictor, then better than sphincter, constrictor, circular constrictor, and radially passing radial dilators. Okay, dilators. So these are the depressors, etc., etc. So what we need is one view. The muscles are, all of them are situated at the same level, in the same layer, with the exception of one, which is attached to the angle of the mouth. So starting first of all with the circular constrictor, we call it orbicularis oris, muscle, orbicularis oris, name also, yes, please. And it has two parts. Part is the, that one is the peripheral. We call it also marginal, peripheral, marginal is official term, M, and the internal one is the labial, L is labial, right? Peripheral and labial, or marginal. So this is the biggest muscle. First part is the circularly oriented, and the lighter one is the labial. So here we have the lip, like that. Lips are reddish, but you can color them, of course. You can color them by different colors. But okay, so peripheral, marginal, labial, inside. Good. And then drawing also the position of the wing of the nose, nasal part. We see there is the philtrum, and then the sulcus nasolabial. But yeah, maybe that we can start with one muscle which is different. The muscle which is deeper, in fact is deep, I would say deep, because the only one is deeper, and this is buccinator. Buccinator is attached or originates from the raphe, from the dense connective tissue band, originating from the pterygoid process of the sphenoid, and attached to the lingula, in fact, the lingula of the mandible. We call it pterygomandibular raphe as a band, pterygomandibular raphe, and it's attached to that modulus, repeating. This is like a knot. We call it modulus in green, which is the condensation of the connective tissue, important for the stability of the angle, stability of mouth. Any damage to the modulus, it leads or causes the different position of the angle. Fine. So this is the buccinator, different muscle. It also contains the opening for the parotid duct. So here passes opening, I would just say parotid duct, because if we use green, so then this is the parotid duct, ductus parotidus. It passes through the or perforates the buccinator and opens into the vestibular oris, or a vestibule at the level of the upper second molar. That's it. So, and then drawing different groups on each side. First of all, starting with the levator labii superior, levator anguli oris, levator labii superioris. Then there is the muscle narrowing the nose. We could draw it also together with the nasal muscles, and it's attached to the upper lip. Levator labii superioris alequinaceae. On the other side, we see minor and major zygomatic muscles, stronger ones. Then caudally inferiorly, we see the mentalis. On the other side, drawing just few lines showing the risorius muscles of the laugh. And then we see the depressor anguli oris, depressor labii inferioris. No, that's it. So why to add more? First of all, that one is the levator labii superioris alequinaceae, narrowing the wing of the nose and elevating the upper lip. This one is a levator labii superioris, or levator of superior of upper lip, we could say, also muscle. That one is the levator, again, levator anguli oris, or in English terminology, levator of angle of the mouth. That one is opposite depressor, again, depressor anguli oris, and that one is depressor labii inferioris. That's it. Mentalis, and I mean that it could be all mentalis. Yeah, okay. Zygomatic muscles. They are also elevators muscles, and these are minor. First one, minor, major. Finished. So very quickly, we have seen the review of the muscles of the head, all the categories. Even in the short review, we have mentioned all of them. No, and then we are approaching to the regions. By the way, one more thing must be mentioned. This is the diagram here. We are looking at the wrinkles in the face. One could be discussed together with the venter frontalis of epicranius. You see that the wrinkles run exactly in the right angle to the course of the muscular fibers. This is important for plastic surgery. So we call this line, because they are based on the arrangement, special arrangements of collagen and elastic fibers in the dermis. We call them Langer's lines. So then please look again at the lines. You see there is the orbicularis oris, and the lines run in right angle. So we have to just mention that, why not here, wrinkles run, they run at the right angle to the course, to the direction of muscles, right? And the wrinkles are based on the lines which are called Langer's lines. We will speak about them again in the topographic regions of the face, but we have to mention them, otherwise we will forget it. This will be a mistake. So wrinkles, done, finished. Okay, concerning the regions, there are many regions, as we said. Some of them are superficial, some of them are deep. So maybe that we could start with short review of the typical regions. So we will not speak about all of them. There is absolutely no time and no place. First of all, we remember this is the frontal region. Frontal region, we will try to describe some typical regions and the architecture of the layers. This region contains the muscles, but it contains superficial nerves belonging to the first branch of trigeminus, then the branches of the temporal superficial artery, but also the veins. They have the connections with the ophthalmic vessels. Then we know that this area has also the connections between the ophthalmic artery and the other arteries. So these interconnections are very important for the practice, for this arterial and venous connections as the spread of infection. So we could say some words to the regions. The title would be the topographical regions or areas, regions, and we divide them into the regions situated in the face and belonging to the neurocranium, neurocranium, and also viscerocranium or viscerocranial, facial part or neural part of the head and facial part of that. Both terms could be used. And starting with some neurocranial regions as the example. So first of all will be frontal region. Frontal region is the region which in fact corresponds with the frons. Frons is the forehead, and forehead has the bony parts of the frontal bone, of course, superior margin of the orbits. Maybe that we could start directly with the layers as the good example, typical layers. Usually we start with the skin. Skin contains or is relatively thick. We see the wrinkles, as we said, and wrinkles run in the right angle, at the right angle to the ventral belly. So this is sufficient. The next layer is subcutis. Subcutis is terminus technicus we will use for description of the subcutaneous layer, where we see some fat and fatty tissue, but important for us are the superficial branches of the nerves. Coming from cranial nerve number 5/1, then also some branches of the auricular. We have seen auriculotemporal nerve from the trigeminus again, but number 3 in subcutis. There are also some superficial veins, not necessary to name them. But then follows the layer of the muscles. They are muscles of facial expression. We could say that this is the frontal, this is the ventral or frontal belly of epicranius, frontal belly of epicranius, correct. And at the same level, there is also part of orbicularis oculi. You see here when we look, there is also part of orbicularis oculi and also the corrugator, supercilia, etc. No need to speak about them. And plus parts of orbicularis orbicularis oculi. That's it. No, and at the same level is the procerus. Also, we said procerus muscle and the corrugators. That's it. Then follows the layer, because within the layer of the muscles are found the arteries. So we have to mention the arteries, as we have seen in the first diagram. It are branches of the ophthalmic artery, because ophthalmic artery is the branch of the internal carotid, we said, and also the branches of the superficial temporal artery. That's it. Veins are absolutely same, so we could say same same veins. No, and number 5, bones, small elevation is glabella anterior at the center of the front, there is small elevation, and tubera frontalia, etc. Nothing else. It doesn't any extra diagram, it doesn't any extra special comments. Starting with the next, as again example, is the occipital region. Also, another example. Looking at the occipital region, this is the region where we see the occipital artery and vein, and then the nerves, which are nerves belonging to the plexus cervicalis, cervical plexus. So it would be complex of the nerves like the occipitalis major, occipitalis minor here, and also that one is a tertius, but is a small nerve. I mean that this would be sufficient for us. So we see also some superficial interconnections, but more important for us, not the deeper area is called suboccipital trigone. But important would be not here, but in one of diagrams in one of our books, we see the dorsal view, important diagram, important information concerning the emissaria, because we have discussed the emissaria in the first diagrams. First of all, in light blue, we see the projection of the sinuses inside. That one is the superosagittal sinus. Here is the confluence sinum, that means the point where join all the sinuses in the posterior part together. That one is the transverse sinus, and then sigmoid, and then opening into the internal jugular vein. So these are sinuses, but on the surface in the darker blue, we see the superficial temporal vein, then interconnection with some varieties. It opens into the parietal emissaria. Parietal emissary veins is open also into the superosagittal sinus at different levels. Here you see the mastoid emissarium and mastoid emissary vein, which opens close to the occipital sinus. Then definitely there is the vertebral venous plexus. It opens also into the condylar emissary. Here superficial we see the occipital vein. So there are more emissaries. I will just mention that in the occipital region, because this is important, we could revise that. Number 1 is the skin. Skin is relatively thick. In the subcutis, what we see in the subcutis, we leave part for the drawing. Subcutis, just branches of the cervical plexus. We have seen it. Then follows number 3, muscle. This is the occipital or posterior belly of epicranius, or occipitofrontal epicranius. Yes. At the same level, number 4 are the veins and arteries. Within the muscle is the occipital artery plus posterior auricular, good, sufficient, artery, definitely. And then important for us are at the same level the veins, maybe better emissary veins. And if we see part, not symmetrical part of the skull, maybe that it could be like that. Here is foramen magnum. At this level, we see the superior sagittal sinus, then confluence of sinuses here, then transverse sinus, and also sigmoid sinus, like that. And in darker blue, is the internal jugular vein. So just very simple sketch showing the projection of the sinuses. You see this internally. So we could say that this is the superior, for instance, superior sagittal sinus. So these are sinuses. That one is the sigmoid sinus. Fine, they are inside. Here is the vein resulting from the fusion of the sinuses. We call it internal jugular vein, and internal jugular vein passes through through the jugular foramen. No, and then using darker blue, drawing the superficial veins like the superficial temporal, and then the connection into the emissary. Another one runs like that, and another emissary, right? Emissary. Here we see also the vein and also the connection with emissary, etc. So we could say that these are emissaries. This is emissary, this is emissary. So you can just add 2 arrows saying that these are emissary veins. And we said that emissary veins represent important routes for spread of infection. These are superficial veins. These are emissary. So I'm sure that this is absolutely sufficient for us. Emissary veins represent the interconnections between or with between the extra and intracranial veins, arrow routes, forming routes of spread of infection, bacterial infection. That's it. Very important. So again, repeating, emissary veins represent interconnections between the extra and intracranial veins, representing or forming the routes of spread of infection. Sufficient. No? Number 5, deep area, that is the suboccipital triangle, trigon. Finished. The same would be the parietal, but what to say to parietal, nothing extra. So the same would be, I just put parietal region will be the same, practically just looking at the, again, emissaries. So just look at the emissary veins, Galea aponeurotica, etc. aponeurotica. So the other structures would not be so important because this description will be same, superficial veins, vessels, absolutely sufficient. So this was the neural part of the some regions belonging to the neural part. But now we have to start with the general description of the regions of the face. So we said that these ones are those belonging to neurocranium. This was first part here. And the second one would be the facial regions. Facial regions, RGG. Facial regions are specific because they have, in fact, uniform architecture of the wall, of the layers, uniform architecture, starting with the layers. So how is with the layers? Usually, first is skin. Skin is thin in the face, also forming wrinkles. Don't forget wrinkles, important for us. Wrinkles run here around the orbicularis oris, orbicularis oculi. Important for plastic surgery. Langer's lines. Again, repeating. This is what we know. Number 2 is subcutis. What we see in the subcutaneous tissue. First of all, there is the fatty tissue, fatty tissue forming a body, corpus adiposum, adipose, also adipose body of the face, then subcutaneous superficial veins, subcutaneous veins, blue veins. Yes, this subcutaneous veins belong to the main vein, which is the facial vein. We have seen facial vein several times. The facial vein has the interconnections, again, interconnections with the following veins, with the first of all, with superficial for other superficial veins, interconnections with superficial veins, which are infra veins colon, infraorbital, yes, infraorbital, then superficial temporal, yes, superficial temporal, then what else? The transversa faciae, we will see all of them, faciae, in the diagrams. Mental, also mental vein, the others, with superficial, better arrow, with superficial, and also with the deep veins, because deep veins or plexuses are extremely important, again, because they are roots of infection. This is number one, the pterygoid plexus, and also with the ophthalmic veins. We said that ophthalmic veins are situated in the orbita, and they belong to the system which opens into the sinuses or the pterygoid plexus, and so on. So again, infection spread, repeating spread of infection, spread between the, so simply, the bacterial infection can pass directly and quickly from the superficial veins into deep veins, into the pterygoid plexus or into the orbit. So important to know. Subcutis, superficial veins, yes, superficial veins, and also the nerves are found in the subcutis, superficial nerves, we would say nerves, and the nerves are sensory branches of cranial nerve number 5/1 to 3, depending where we are, and then follows number 2, number 3. Then they are the layer of the muscles of the face, or also deeper are muscles of mastication. So muscles of the face, including nerve, cranial nerve number 7, supplying muscles of the face. Then these nerves had also interconnection. The interconnection is called superficial ansa cervicalis, superficial ansa cervicalis, and this ansa cervicalis consists of the ramus colli of nerve number 7, plus with the transversus colli of the cervical plexus, yes, ramus colli, and this interconnection is called ansa. This is the ansa supplying the platysma, because platysma, we know, is the muscle that belongs to the category of the muscles of facial expression, although it's situated on the neck. No, muscles of the face are muscles of facial expression. Deeper are the masticatory muscle, masticatory muscles with cranial nerve 5/3, nothing else. No, at the same level, they are the arteries, because the arteries are situated within the muscles. So facial artery, infraorbital, orbital artery, no, and mental also, mental artery, better handwriting. Yeah, sorry, infraorbital must be improved. Infraorbital and also mental, infraorbital mental. That's it. Fine. Mental artery. No. What else? Then we need also information concern. Yeah, pulsation. Where we can feel pulsation. No. In fact, on this facial, that means where the facial artery crosses the margin of mandible, one thing, and the second one, the superficial temporal on the face. So we have diagram. Here we can palpate the artery pulsation of the facial artery, and here in front of the tragus, this process we can feel the pulsation, not in every individual, but here we can feel the pulsation of the superficial temporal artery. Good. So facial and also superficial temporal, important for the descriptions and so on. No, and number 5, lymphatic drainage, lymphatic drainage, specific for each part, usually into the either submental, from the face definitely, submandibular, mainly submandibular lymph nodes. Yeah, but depending, there are also the parotid from the area above the parotid gland. There are also some collectors that open directly into the submandibular. Fine, and then running ahead. Again, 1-2 examples of the regions. First would be, what do you think about the parotidomasseteric region? Parotidomasseteric, as the name says, this is the region comprising the parotid gland and also masseter. For these regions, we have many diagrams. This could be a good example, maybe starting with that one, although it shows also submandibular. Note, please, that here's the parotid gland. We see the course of the facial nerve, dividing it into the superficial deep part. We will draw an extra diagram. In front of that, we see the ventrally the facial vein and facial artery. After removal of the gland, we see also deep structures. First of all, the masseter with this deep portion, superficial portion, crossed by the branches of the facial nerve. Here is the ramus colli. We said that ramus colli descends, forming the ansa. Here is the ramus marginalis of mandible, crossing the vein and artery, and then dorsally posterior ascends in the region also the superficial temporal artery and vein. So this could be all to that. So parotidomasseteric boundary. We start with boundaries. Yes, boundaries. No, zygomatic arch, easel, zygomatic arch superiorly, margin of mandible caudally, mandible, so craniocaudally is that one. No, and laterally, just you can place here masseter, and then we see that also in the range of masseter ventrally, and in fact tragus posteriorly. I mean that it could be all. And then looking at the layers, layers. No, maybe the best would be to draw first of all horizontal section, because this section shows the most important structure, starting with the mandible, medial pterygoid. Maybe that is not bad to draw also. Why not to use, oh my God, this would be even better. Drawing the pterygoid muscle, mandible, then masseter. And here I'm drawing, because it doesn't belong to the parotidomasseteric, because first of all here drawing the parotid gland like that, with the external carotid, retromandibular, facial nerve, dividing it by its course, and then running ventrally, coloring the structures inside, artery, yes, the mandible, correct, in very light red, the medial pterygoid, because this is not the area, this is the area. Dark red for the masseter, and dark green surrounding, for the line surrounding the gland, because the gland is surrounded by two laminae, two laminae of the parotid fascia. And this fascia also covers completely the muscle, the masseter. So the fascia is called parotidomasseteric fascia. And here is the gland, maybe just light vertical hatching, can be used for coloring or even both, for the gland, and traditional yellow for the mandible. Because we see the medial pterygoid. For dentistry, important is the position of the nerve, artery, and vein situated close to the mandible, to the opening to the canal. And here ventrally lies the lingual nerve. It's not bad, because they use it for trunk anesthesia. They place the tip of the needle into the cleft between the mandible and medial pterygoid, and the space is called pterygomandibular. So this is not a part of our horizontal section showing the parotidomasseteric region, but we can just add here very thin lines showing that this is the complex of the inferior alveolar artery plus vein plus nerve. I would say in the pterygomandibular space. I would say trunk anesthesia sufficient. Trunk anesthesia, stop dentistry. We will not speak about the region in detail. We will see it in one section, but why not to use it? Here is the lingual nerve, so please, lingual nerve. But again, this is not part of the parotidomasseter, because parotidomasseter is completely surrounded by the fascia. What we see medially is the external carotid artery. More dorsally lies the mandibular vein. Yes, here is the nerve number 7. Then branches. Then here is the masseter muscle, and the fascia covering both is called the parotidomasseteric fascia. And as you see, the parotidomasseteric fascia has 2 layers, 2 laminae, yes, that one is superficial and that one is deep. deep lamina, deep, superficial and deep, easy. And within the gland, drawing also minimum 2, 3, 4 lymph nodes. Some of them are deep, few are superficial. So these are lymph nodes. Lymph nodes. No, that's it. Lymph nodes. So as we see the no, it's not all. As we see the section, why not to draw using very light blue? We need also one line showing the duct. This is the duct. This is the duct. Yes, it lies on the fascia. Duct lies on the fascia. Correct. Good. And then what else? Layers. Quickly, one is the skin, relatively thin. Then soup plus hair, definitely. Then number 2 is the subcutis. What we see in subcutis, some fat, platysma also crossing the area, and sensory branches of trigeminus, mandibular nerve. Quite clear. Number 3 is the parotis gland. So parotid gland plus fascia. We said that this is that fascia, parotidomasseteric. Maybe that we could say parotidomasseteric fascia, the same color, masseteric fascia. In the we call it parotid bed, which is lined by the connective tissue. The contents of the bed is the gland and etc. This is not necessary to repeat it. Number 4 is the masseter. So masseter muscle is strong, a strong elevator and slight protractor of the mandible. Plus the same fascia, no need to add anything else, fascia. And then also the bony part is the mandible. Mandible better is the ramus and body, just mandible. This is better because angle of mandible, that's it. No? And one more, what do you think about one more region? Here we have also simple drawing showing the duct. Sometimes on the duct is the accessory. Here's the gland. Here you see the marginal branch of the trigeminus, etc. No, maybe before we will leave the region, we could say also topographic relations. Why not? Posterior is the auriculotemporal nerve plus superficial temporal artery plus vein. Posteriorly also dorsally posterior also cranial nerve number 7, because we see this is here. Medially there is the external carotid artery. Again, carotid artery. Note that external artery could be found either within the gland, but also could be found on this medial surface. And also ventilation duct. No, maybe that now is better. So we mentioned also something concerning topographic relations. Pulsation of the artery, we said. No? And as the last example could be the labial. What do you think? Labial region. There are more also, of course. Labial region is good example because the labia, the lips, are the typical examples of the area where the skin is not keratinized. So we simply see the red color of the lips. No, for this region, we practically don't need anything. No, maybe that first of all, description of the layers. Skin is thin skin. We control the color of the lips, color which is light red, bright. In subcutis, what we see are the branches or the tributaries of the facial vein, facial veins, facial, mental vein, then superficial nerves from second and also third branch of trigeminus. Motor is deeper, just to revise that there is the 7 skin subcutis. Then follows the layer of the muscles. Again, looking at the orbicularis oris, and then the course of the muscles. Important again is the, as we said, the modiolus for the position, and deeper muscle is the buccinator. So this is nothing else. Number 4, because we already said, facial at the same level lies the facial artery. We said several times that the arteries are situated at the same level as the muscles. Again, we mentioned anastomosis with the others, with in labial with the mental artery. More cranially is the ophthalmic, but is not here, is not in this area. Ophthalmic is not just mental, and also cranially, not in the area, cranially in the face also with the infraorbital, etc. You see, just to remember that the connections could be even in the different position, far away from this area, but they exist. The same layer contains the, and then we need next page, running to the end. We could mention also the, no, maybe it's not bad to show you the nose, then the lips, like that, and the whole area surrounded by interrupted line, colored by yellow, represent the dangerous area, risky, dangerous area, because this area for quick spread of different parts of infection. You saw why? Because inside there are the network. There is a network of lymphatic capillaries plus venous network. So, and the combination of both is really the area from where the spread, the infection will spread quickly from one area to the other one, so very quickly. So this is important. So the network of collectors. Concerning the lymphatic, lymph is drained, no, simply into 2 areas, from the central portion, inferior incisor, central part of the inferior lip, into the submental lymph nodes, LN, and from the lateral parts to the submandibular. to the submandibular lymph nodes sufficient. So I mean that this could be all as an example of the areas belonging to the facial part of the or as a typical example of the superficial area, superficial region. No, and what follows? No, we have not that much time, but one region as the good example of the deep regions must be explained, and the second and third one I will send you as tradition by as the handouts. We have to start with the regiotemporal region, and also infratemporal region, temporal and infratemporal region. Using one drawing, both together, temporal and infratemporal together, and then also starting with the diagram showing the infratemporal area. The temporal area and infratemporal area are situated below the zygomatic arch. So if you look at these two diagrams, smaller, but maybe it's not bad. The lateral view, you see the area occupied by the temporalis muscle. So this is the temporal area, temporal region. Then here you see the zygomatic arch, and then although smaller diagram, but still good, here we see the cavity below the zygomatic arch, below the inferior margin of the zygomatic bone. So it's called infratemporal area, infratemporal fossa, or infratemporal region. And the deepest area of the infratemporal region would be the pterygopalatine. But I have another very nice diagram from Netter's Atlas, and this is the medial view. We are inside the infratemporal region. We see also the external carotid artery dividing here into the superficial temporal and the maxillary. You see that the maxillary crosses medially the neck of the mandible, running superior anterior between the muscles of mastication, between the pterygoid muscles. So very nice diagram. And then we said that the deepest part of this infratemporal fossa would be the depression, which is called the pterygopalatine fossa. And for that, I have also some diagrams, minimum two. We are looking at we are in the infratemporal fossa again, but this is the lateral view, looking at the external carotid artery, then the maxillary artery, which passes into the area between the pterygoid muscles. And another diagram is starting first of all with this drawing, where we have the whole area with the mandible, etc., zygomatic arch. After removal of part of the arch plus mandible, we see we are still, we are now, of course, we are still in the infratemporal fossa, but the deepest part between the pterygoid process and this is the lateral lamina and the tuber of maxilla is that cleft, is a pyramidal cleft, a fissure called pterygopalatine fossa. For that fossa, for description of fossa, we don't have time, but I will send you separately as a handout. So we have time just for last drawing for today. Last drawing in the coronal, looking at the coronal section. This coronal section shows the temporal squama opening for the mandibular nerve. Is too wide. It can't be. Must be smaller. So now it's better. Okay. And then pterygoid process with two laminae just sketching two laminae is like that. Okay, good. Section through the bone, good. Here we see the nerve passing through the oval foramen 5/3, bone yellowish, outlines clear. No, inferiorly, because we have to draw also the position of the zygomatic arch, arcus zygomaticus. Then from that arch descends the masseter to attach to the mandible like that. On medial side descends the medial pterygoid. Of course, usually the space is narrower, but for the better description, we use usually larger or drawings with the larger areas. The muscles found in this area, first of all, laterally, masseter, medially, medial pterygoid, then two heads of lateral pterygoid, as we see, like that. This is the mandible. Again, the mandible on the section with projection of the mandible, then attachment of the temporalis. This must be like that, temporalis muscle, yes, attached to the coronoid process of mandible, and laterally there is small temporoparietal muscle, a part of the epicranius, parietal muscle. This one, no, also light red could be. This one is temporalis muscle on the section. Temporalis, temporoparietal, zygomatic arch, correct. Mandible, why not? Mandible. Masseter, laterally, masseter. Good. Medial pterygoid. You see how many nice structures are found. Pterygoid. Two heads of lateral pterygoid. Pterygoid, yes. The nerve, mandibular, dividing here into the nerves, supplying all these muscles in the area. No, descending also to the mandible as inferior alveolar. And what do you think? Also drawing one more, which runs medially towards the tongue. No, this is the lingual nerve, definitely. This one is the inferior alveolar. Yes. What else? No, the artery, definitely. Here we see the maxillary artery. It lies on the medial side of the neck of a mandible. Maxillary artery. Correct. No? So we are in the temporal region. This is the temporal fossa. And here we are in the infratemporal. We have to mention also thick fascia of the temporalis with two layers. So these two layers represent, both of them, the temporal fascia. Temporal fascia covers as a strong fascia the temporalis. So we see all the structures found in the temporal and infratemporal region. No, and on the surface we have to draw also the neurovascular bundle as usually, which is the nerve, artery and vein, repeating it here because there is no place on that side. Drawing the auricular, we said several times, auriculotemporal nerve and superficial temporal artery plus vein. No, good. No, if we draw the structures, why not to draw also? I know that it doesn't belong to the temporal infratemporal region. Why not draw also the the facial artery and vein. No, on one section. Fine. No, and the last two sentences for today. Concerning the temporal region, boundary of the temporal region is easy, descending from the superior temporal line on the lateral side of the temporal squama, and then zygomatic arch, yes. And concerning the contents is easy because in the temporal area, skin also, the contents of the temporal area, temporal fossa is the temporalis muscle, plus its strong fascia, then deep, the artery supplying the muscle. This is the very last text for this moment. Contents, just some words. Deep temporal arteries plus veins, auriculo temporal nerve. We mentioned it also several times. Then what else? Temporoparietal parietal muscle belonging to epicranius. No, that's it. So I mean that this is all to the temporal area, of course, plus branches of cranial nerve number 5-3, but temporoparietal has number 7. This is quite logical because this belongs to the epicranius. No. So this is all for this moment. We started with the temporal region. It was easy, but infratemporal fossa needs a special description. So what I have to do is to complete 3 regions: infratemporal fossa. Then the deepest part is, as we have seen, the pterygopalatine fossa, and finally also the parapharyngeal space. So the 3 pages should be sent to you. It's, as we said, a rich program for one lecture, because it comprises not only the coverings of the head and also the nerve and blood supply, a review of the muscles, then a review of some typical regions in the facial area, then neural part of the head, and then deep regions. This is really too much to do. Thank you for attention, and I will send it to you and see you in the next week.